So once again, on behalf of Tech Salud, thank you for coming all the way to Cancún. Thank you for being here. Gracias a todos por venir. So we're going to start with this session, which is new for us. And we're going to, there were more than 30 submissions for cases, and now we choose 4. And so, you know Sandeep Nathan from yesterday. And so we're going to moderate this. So let's go right to it. We're going to invite Jose Fernando Mejia to present this first case.
Buenos días a todos. Soy José Fernando Mejía, residente de cardiología del Hospital Christus Movers, alta especialidad de Monterrey, Nuevo León. Y hoy traigo a cotación este caso clínico para ilustrar que en pacientes con disfunción valvular protésica que desarrollan choque cardiogénico, que tienen un alto riesgo quirúrgico, las estrategias percutáneas mínimamente invasivas se vuelven una ventana de oportunidad para el tratamiento de estos pacientes. El equipo multidisciplinario que trató en este caso fue liderado por el doctor José Ramón Aspiri, a quien agradezco la oportunidad de compartir esta experiencia. Definitivamente esto es un escenario clínico complejo por la combinación de la disfunción valvular protésica acompañada por una miocardiopatía reversible que se traduce en una disfunción ventricular aguda y que termina en un choque cardiogénico. Definitivamente un reto hemodinámico para cualquiera de nosotros como médicos tratantes. Se trata de una mujer octogenaria conocida ya por el reemplazo valvular mitral desde el 2021 con una prótesis Magna Is número 29, además conocida por fibrilación auricular. La paciente es portadora de marcapasos, también tiene diagnóstico de hipertensión pulmonar y sufrió un ataque isquémico transitorio en el año 2022. Su tratamiento crónico se basa en anticoagulación con warfarina, manejo para la frecuencia y antiarrítmicos con amiodarona y además diuréticos de asa de manera permanente. Su cuadro clínico inició alrededor de 6 meses antes, con las que se presentó con disnea de esfuerzos. Sin embargo, en los días previos a su ingreso, pues tiene disnea de reposo, notan aumento del volumen de la circunferencia abdominal y además edema periférico. Es lo que la lleva y la motiva a ir a urgencias en ese momento. Llegó con estos signos vitales y llama la atención que en la exploración física predominaba datos clínicos de falla ventricular de predominio derecho y además un soplo diastólico en el foco mitral grado 3 de 6 de Levin irradiado hacia la axila y definitivamente hallazgos clínicos de congestión venosa sistémica. Un electrocardiograma inicial en el que vemos un ritmo de estimulación ventricular desde el ápex del ventrículo derecho y en el ecocardiograma inicial pudimos observar la restricción del movimiento de las valvas de la prótesis valvular mitral acompañada de un jet de insuficiencia de moderada a severa. Y en el análisis de los flujos, un gradiente medio de 13 milímetros de mercurio. Además, un índice Doppler de 2.6 y un área valvular efectiva de 0.69 centímetros cuadrados, lo que no quedaba duda que la paciente o la prótesis presentaba una estenosis significativa. Sumado a esto, una insuficiencia tricuspidia severa que traducía y se podía calcular una presión sistólica de la arteria pulmonar de 90 milímetros de mercurio, además con dilatación del ventrículo derecho, disfunción sistólica del mismo con aplanamiento del septum interventricular y cabe mencionar que en este momento la paciente tenía función ventricular izquierda preservada con una fracción de eyección calculada por método biplanar del 53%. Esta fue la radiografía con la que ingresó, la que tienen a su lado derecho, caracterizada básicamente por un derrame pleural derecho. En ese momento se inició el tratamiento con diuréticos de asa y oxigenoterapia, con lo que en la secuencia de los días la radiografía mejoró y clínicamente la paciente estuvo más estable. Sin embargo, al encontrar los hallazgos de la disfunción protésica valvular, pues se planteó a la paciente la necesidad de hacer un procedimiento para liberar la estenosis de la prótesis mitral, lo que conllevó que la paciente tuviera mucha preocupación y ansiedad en el momento de recibir la noticia. Llama la atención que unas horas después de esta plática, la paciente empieza con hipotensión, disnea, hipoxemia y esta radiografía que tienen a su lado izquierdo, donde ya se observa una congestión venosa pulmonar. Se repite un electrocardiograma donde está en ritmo de fibrilación auricular, y además un patrón de isquemia subepicárdica generalizada sin tener un patrón coronario específico. Se repite un ecocardiograma donde se encuentra una disfunción ventricular y con un patrón de apical ballooning típico que hace la sospecha de una miocardiopatía por Takotsubo. Vemos aquí en el bullseye del strain longitudinal global, donde las alteraciones de deformación miocárdica son en el prominio del ápice y los segmentos más basales se encuentran preservados, con un strain longitudinal global de menos 3.9% en este momento. Por lo que ante este estado clínico de la paciente, pues se traslada a terapia intensiva, se empieza tratamiento con diuresis con furosemida intravenosa en infusión continua, además oxigenoterapia de alto flujo y escalarla con presión positiva, y además soporte vasopresor e inotrópicos con la combinación de norepinefrina, dobutamina y milrinona en ese momento para favorecer la vasodilatación pulmonar. Se diagnosticó un choque cardiogénico SCAI-C de perfil cardiometabólico, por lo que en el contexto de la paciente se sometió a una discusión interdisciplinaria para definir la estrategia invasiva. En este caso, pues, ante una paciente de alto riesgo quirúrgico con un STS de 27% y un Euroscore del 22.3%, se optó por el implante percutáneo de un valve-in-valve mitral. En el momento del procedimiento se hizo una angiografía coronaria en el que se confirmó que no había enfermedad coronaria obstructiva que apoya más el diagnóstico de una miocardiopatía por Takotsubo, y cabe mencionar que se hizo el análisis por tomografía acerca de las características de la prótesis y se encontró un True ID de 27 milímetros, y además se hizo una reconstrucción de un posible tracto de salida del ventrículo izquierdo para así poder definir la estrategia de utilizar una prótesis balón expansible número 26 y esto sumarle un cc a la entrega para evitar las dos complicaciones principales, que es la migración de la prótesis y también la obstrucción del tracto de salida del ventrículo izquierdo. Se hizo un abordaje transeptal teniendo en cuenta que colocar la prótesis al revés o el faldón en la parte proximal del sistema de liberación para poder entregar la prótesis a favor del flujo anterógrado en la prótesis mitral. El procedimiento se llevó a cabo con éxito, obteniendo estos resultados. El gradiente medio transmitral bajó a 5 milímetros de mercurio, la presión sistólica de la arteria pulmonar de 90 pasó a estar a 45, 50 milímetros de mercurio. En los días subsiguientes, el gasto cardíaco aumentó hasta 6 litros por minuto. Hubo una resolución ecocardiográfica del patrón de Takotsubo. Como vemos en la imagen, el strain longitudinal global control, hay una resolución total de las alteraciones de la deformación miocárdica. La paciente se pudo extubar al tercer día posimplante y un alta hospitalaria 10 días después con un favorable desenlace clínico para la paciente con este tratamiento médico. Y pues este caso nos parece excepcional, pues porque lograr la reversión de una miocardiopatía reversible junto con un procedimiento estructural mínimamente invasivo con éxito, pues nos llevó a esto a través de la toma de decisión en un equipo multidisciplinario, el uso estratégico de la combinación de vasopresores e inotrópicos y además pues que hay escasa información de este tipo de procedimientos en pacientes con disfunción ventricular aguda debido a una miocardiopatía reversible como es el Takotsubo. Y eso, muchas gracias.
First of all, that was a great presentation. Congratulations on an excellent case. I would encourage you to write this up and submit this for publication. So if it's truly a unique set of circumstances, I think it's very worthwhile considering it for publication. How did the patient do during the procedure? Did they need any vasoactive agents, vasopressors, mechanical circulatory support? Did they tolerate the procedure well?
En el momento del procedimiento inicial, si hubo deterioro del estado hemodinámico, requirió incluso sumir el soporte vasopresor, no se llegó a necesitar soporte mecánico. Sin embargo, en el momento de liberar la prótesis, todos estos parámetros mejoraron. Al momento de mejorar la obstrucción de la válvula mitral, la paciente progresivamente mejoró todo su estado hemodinámico.
So also, at some point, did you consider to do a right heart catheterization?
Sí, de hecho, estuvo con catéter Swan-Ganz durante
okay.
su estancia en UCI, monitoreando todos los parámetros para poder
Eso
darle un mejor manejo.
fue en el momento de que se deterioró.
Sí, correcto, con el que se trasladó a UCI.
¿Y consideraron soporte mecánico circulatorio?
Se tenía como backup, pero en el momento que la paciente se estabilizó y los parámetros hemodinámicos y tanto el lactato empezó a mejorar, la presión, la diuresis y la perfusión periférica, no se llegó a necesitar, pero definitivamente se tenía en mente utilizar un soporte mecánico biventricular en este caso por las características del paciente.
Would you have done some mechanical support in this case?
You know, I think it's nice to have it, but when you have this much equipment going transeptal and so forth, it makes it a little bit tricky. So, you know, I think when she had Takotsubo cardiomyopathy, we might have bailed her out with an Impella just to stabilize things, and then, you know, you can continue that for the procedure. Putting an 81-year-old on ECMO for any reason is always a little bit tricky. We've done it before, but you'd like to avoid it.
Any other comments or questions from the audience? Yes, Guillermo.
So I wasn't sure if I was going to make a comment like this, but I think the patient went into atrial fibrillation. So I don't know whether Takotsubo is the most proper way. In my mind, as somebody who had mitral stenosis, who had heart failure with mitral stenosis, then he went into AFib, rapid AFib, and he loses the atrial kick, loses the filling time, and then went into shock as a consequence of the atrial fibrillation. Yes, the morphology, the changes in the heart, but I think that's the reason why she worsened. You know, if you had an EKG in sinus rhythm or V pacing, but regular rate, and then you went into atrial fibrillation. So I think that is the culprit for the worsening in the clinical setting. So I wonder if you would have just done a cardioversion at that time. I mean, once probably the whole consequence of the shock state as due to the atrial fibrillation might have not reversed immediately. And there is no question that needed the valve in that procedure. But I think what made her sick was the development of atrial fibrillation. Those would be my thoughts. But maybe comments or for somebody else? Because MS and rapid AFib, they don't work very well.
So we're going to move on. Gracias.
Gracias.
Sorry, doctor.
Hola, pues muy buen caso.
Gracias.
Y si hicieron cateterismo cardíaco derecho, tenían resistencias vasculares pulmonares.
Sí, estaban altas.
Altas.
Sí.
Entonces, esta era una hipertensión pulmonar precapilar y poscapilar combinada.
Correcto, sí.
Aquí el único punto es el comentario sobre el sildenafil. En este tipo de hipertensión pulmonar se ha usado todos los medicamentos que quiera, tadalafil, epoprostenol, sildenafil, macitentan, ambrisentan, y lo único que se ha demostrado es que aumenta los eventos adversos y los pacientes tienen peor evolución. Pues es nada más como un comentario al cárcel porque el caso es muy bueno. Sí, claro, hipertensión pulmonar precapilar y postcapilar combinada por insuficiencia cardíaca o por valvulopatía o falla ventricular izquierda con fracción de expulsión reducida.
Gracias. Listo, gracias a todos. Permiso.
Okay, next up we have Dr. Priya Nair discussing a case of multivessel disease in AMI complicated by cardiogenic shock. Priya is from my center, from University of Chicago.
Hi everyone, my name is Priya Nair and I am a second-year internal medicine and pediatrics resident at the University of Chicago. Thank you to the LATAM Shock Committee for the opportunity to present my case. Today I'll be presenting a case called Beyond the Golden Day. And it's about navigating treatment delays when the patient falls outside of the clinical trial or guideline parameters. My co-authors and I have no disclosures. To start with a little bit of background, I know you guys have seen the Sankey diagram earlier in the conference, but I just want to highlight that cardiogenic shock after acute MI still carries devastating outcomes. The cardiogenic shock working group highlights that patients, especially stage B, often deteriorate quickly within 24 hours, the golden day. The main takeaway from the Sankey diagram is that over 50% of patients that presented initially with stage B and C shock progressed to a worse sky stage in 24 hours without intervention. I know you've seen this diagram as well, but in 2023, Cochin and his colleagues found that after the first hour, every 10-minute delay in PCI increased mortality by 3 to 4%, and delays over 6 hours pushed mortality above 80%, as seen in the pink line. Now, when STEMI is complicated by multivessel disease, management can become especially challenging. Complete revascularization is beneficial in stable patients, but guidelines in shock favor a culprit-only approach to balance ischemic benefit with procedural risk. Focusing a little bit on MCS, the balloon pump is historically common and widely used. However, the IABP Shock 2 trial showed no mortality benefit in AMI-ICS. Impella, in contrast, provides active LV unloading, and in the PROTECT 2 trial showed benefit in high-risk PCI, and the more recent DanGer Shock trial demonstrated mortality benefit in AMI cardiogenic shock, although this population was younger with fewer comorbidities. Now let's move on to our case. Our patient was a 75-year-old woman with hypertension, diabetes, and dyslipidemia. She presented with generalized weakness, no chest pain. On arrival, she was tachycardic with a narrow pulse pressure, but was normotensive. Her EKG shown here demonstrated non-classic anterior ischemia with atrial fibrillation. The cath lab was then activated for STEMI alert. In the cath lab, her angiogram revealed extensive 3-vessel disease. The LAD was subtotally occluded with diffuse disease. The left circumflex had multiple severe lesions, and the RCA was dominant and diffusely diseased with an occluded PDA. In short, all 3 of her major vessels were compromised. Initially, no PCI was performed because of the complexity of her disease, being chest pain-free, and the opportunity for CABG to be considered. She was intubated, supported with the balloon pump, and a swan was placed. The initial swan numbers are on the screen and are significant for a wedge of 31, a mixed venous of 21, and a cardiac output of 2.4. The main information on this slide here is that her initial lactate was 8.3 and she was hypotensive. Although, remember, on arrival to the ED, she was normotensive. And the reason the LAD was not acted on at this time, it was because it was thought to be maybe a chronic LAD lesion and more of a type 2 picture. After cardiothoracic surgery evaluated her, they found her not to be a candidate for CABG due to her age and comorbidities, and unfortunately she was not a candidate for durable MCS as well due to her small LV cavity and renal impairment. Over the next 48 hours, her condition worsened. In fact, if we were going by sky stages, we would see that she progressed from stage B to stage D shock. She required increasing vasopressors and diuretics and developed an acute kidney injury requiring dialysis. Her ejection fraction was less than 20%, and she had severe regional wall abnormalities. Despite balloon pump, she remained unstable. So after a combined discussion with family, another operator, and the shock team, they decided to proceed with a high-risk PCI. This kind of led us down a road of many decisions. Do we continue with the balloon pump support? Do we escalate to a different type of mechanical circulatory support? How many vessels should we target? Is it worth going after that LAD that might have caused that initial anterior ischemia? And if we do escalate MCS, should we wean it in the cath lab? She ended up undergoing the IABP removal and underwent a single-access Impella-assisted PCI of the LAD, the left circumflex, and RCA with an impressive over 160 millimeters of stent deployed in a single session. The decision was made at the end of the case to remove the Impella due to the potential of limb ischemia. In the following slides, we'll demonstrate the before and after each intervention. Here we see the LAD, the lesion crossed with a microcatheter and Fielder XT, pre-dilated with an NC balloon, treated with an overlapping Onyx Frontier DES. Here we see the left circumflex, the OM stented with an Onyx Frontier after NC balloon, and the mid lesion pre-dilated with the NC balloon and angiosculpt, and then treated with an overlapping Onyx Frontier DES. Then we have the RCA. The lesion was modified with a 3 millimeter shockwave IVL and stented with an Onyx Frontier DES. After the procedure, her hemodynamics improved significantly. Most notably, her blood pressure improved, her cardiac output rose, and her mixed venous increased. Despite dialysis requiring kidney injury, she stabilized and was eventually discharged to rehab with an improved ejection fraction of 43%. I think this case highlights several important challenges. Number one, the patient presented in stage B shock, an optimal window for early intervention, especially in those 24 hours or golden day. However, because she had no chest pain and her disease appeared complex and chronic, PCI was delayed for CABG to be considered. This delay likely contributed to her hemodynamic collapse and subsequent acute kidney injury. The balloon pump, while commonly used, didn't provide meaningful benefit, which is consistent with what we know from the IABP SHOCK 2 trial. Impella ultimately did improve her hemodynamics, but it was deployed late. It's also important to note that our patient would not have qualified for major trials such as Danger Shock, which studied younger, less comorbid patients. And I think this raises an important question about whether the benefits observed in younger patients can be extrapolated to older, more frail individuals. Finally, the aggressive revascularization strategy in this case, more than 160 millimeters of stent, exceeded what is usually considered safe in elderly and frail individuals. Overall, I think this case highlights the idea of considering patients that fall outside of the clinical trial parameters. Looking at the stenting, the more than 160 millimeters, that is the extreme end of what's been reported in literature. The extent of stenting in this patient's age and comorbidities falls outside of the syntax and culprit shock trials. Yet in this situation, it was necessary and ultimately deemed successful. And despite this aggressive revascularization, the patient has done remarkably well. She is now off diuretics, and as of this August, her ejection fraction has recovered to 45%. In fact, 1 week ago, on September 22nd, Dr. Marcotte and Dr. Moeller, the Danger Shock investigators, published a new data in AMI cardiogenic shock showing that intermediate multivessel PCI was associated with a 60% lower odds of all-cause mortality compared with culprit-only PCI. So this is a developing area of research. I also want to touch on the MCS use in this case. We know from recent data, including a 2023 paper by Dr. Basir and his colleagues, that early initiation of mechanical circulatory support in AMI-related shock improves outcomes. The Danger Shock trial has further clarified the role of Impella compared with standard care. And at the most recent ESC conference, we saw long-term follow-up showing not only improved mortality at 10 years, but also a major difference in median survival. Ultimately, management must be individualized with a team-based approach, timely reperfusion, and a thoughtful use of mechanical circulatory support. I'd like to thank my mentor, Dr. Nathan, for his guidance and support, and the conference organizers for the opportunity to present. Thank you.
Good, great presentation, great case. I read it before and I was very interested in this. So some things, for example, have you changed in your hospital the approach to door-to-balloon time when a patient is in shock? I mean, you don't care anymore about that time and you start working more on the shock aspect of the patient? And the second thing is, do you, in a case like this, when you get to the cath lab, do you upfront get the MCS before even maybe have the angiogram, or you probably do all the angiogram and then put the MCS? Because I wonder if it was upfront, did you think about going for Impella from the beginning and not the balloon pump?
Yeah, I mean, I think those are two really great questions. I think, practically speaking, things are done sort of simultaneously. So, assessing the patient by LVDP and blood pressure trend, if there's any data that we have available, notably lactate, that's always nice to have. Sometimes it's happening so quickly we don't have any lab data at all. I think, the spirit of MCS upfront versus later is, are you going to complete your entire intervention and then put it in at the end, as opposed to just kind of working at the same time? In the United States, we're still very much beholden to the door to balloon time. That said, I think in trained hands and experienced centers, you can put in whatever flavor of mechanical circulatory support you want relatively quickly. So the practical answer is that things are happening simultaneously. The choice of balloon pump was sort of an interesting one because, it happened in our center and we do have all of the devices available. I think the concern was that there was PAD, they shot the leg, there is PAD. The patient is older, frailer, and historically just scanning the chart, maybe she had sort of avoided medical care a little bit. So we weren't entirely sure what the ultimate trajectory for this patient was. So once we discussed as a multidisciplinary shock team, I think everyone weighed in and said, if we're going for it, then, a balloon pump is certainly not going to carry the day for somebody as sick as she was. And very importantly, if you put in a balloon pump, I think that's okay, so long as you're objectively trending the patient. And if the patient is objectively trending in the wrong direction, they're not going to magically get better if you don't do something significantly different.
Great case. I have a question, you and the panel. Any value in doing viability testing in patients with multivessel disease, low cardiac index that appears to be chronic?
Yeah, I think that's another great question. I mean, I think that in selected cases, there's still value in viability testing. I will tell you that my practice has largely abandoned use of SPECT or dobutamine, and when viability for CTO planning is really in the mix, we're getting cardiac MRI to look at the thickness of the scar in the target zone, right? For somebody this sick, we thought, A, that's not feasible, and B, the anterior wall wasn't akinetic. There was still thickness to it, albeit with a recent injury. There was a thickness to it and some contractility, and so we thought it would be worthwhile getting it open. That said, I was the case operator for the actual intervention. It felt very gritty. It felt more like a CTO than it felt like fresh thrombus. There was not much fresh thrombus in there at all. So in the end, I think probably what happened here is that atrial fibrillation basically precipitated AFib rears its ugly head again, and precipitated ST elevations. There's probably some acute component, but everything in there, as you saw from the case description, angiosculp, shockwave, microcatheters and tapered wires and so forth, a lot of it was quite chronic. Barbara.
So yeah, I think that makes a lot of sense, right? And there's not a lot of people who can tolerate PA-SAT of 21% without chronicity to that, right? But clearly it wasn't so long-standing that the LV hadn't dilated and things like that. I think this is a really good case, and Priyo, you did a great job. All three of us were saying we can't believe that you're a second-year resident. You were very polished in saying that. But for the case itself, I think ultimately it shows the limitations of hemodynamic support devices. What else are you going to do? You're going to put an Impella in, cause an ischemic limb. You can talk about 5.5, but then probably you're going to have to intubate her, which you got away with not doing, which was great, right? And so if you're left with a kind of a balloon pump setting to kind of get them, over the hump, and it's to your point, Sandeep, as long as you're monitoring them closely with serial lactated and hemodynamics, that way if there's a trigger that the patient is not responding or getting worse, then you can kind of go there and escalate. But I also think that it's really valuable to talk about just the revascularization itself. You can talk about what the potential culprit for this is, but ultimately this is global ischemia, and at the end of the day, when you're acutely doing something in the heat of the moment, doing 3 vessels like this would have been a huge task and likely hurt the patient. But if you give her the day or two that she had to cool off, I think that takes all of that risk and diminishes it quite significantly.
Yeah, I think, thank you for those comments, Babar. At every step of the way, I thought to myself and said to myself, I'm going to take all kinds of criticisms from my partners for doing this and doing as much as we did. I will say, in a weird sort of way, the fact that she developed AKI before and was heading towards dialysis really liberated us to just go for broke and try to fix absolutely everything. I think, if we got to some round number of contrast, we would have probably stopped. But, despite a lot of calcium modification and so forth, we did get a satisfactory enough result with the proximal vessels. The distal vessels are still pretty trashy. But I wonder, now that it's been opened up, as with CTOs, you go back a month later and the distal vessels all look a little bit better than at the end of the last case.
So, and this patient did well, but I think you wanted to make the point that since she wasn't revascularized in the first 24 hours, that's what made her go down in her. So you suggested maybe in your paper that if she would have been revascularized on the first day or on the first hours, that would have been better. Maybe even like emergent surgery or something. I mean, maybe she wasn't a candidate for surgery, yeah. or revascularization. But to think about doing 3 vessels up front without the proper support, that was maybe a hard decision to take at that time.
We are fortunate to work with incredibly talented and very aggressive surgeons, but I think her frailty, we objectively calculated her STS score, and it was some astronomical number, with her frailty, her new kidney dysfunction, elevated LFTs, and so forth. And so I think surgery was worth considering. We did consider it. We had a conversation about it, and then the surgeon said absolutely not.
Yeah. So the procedure was done on day number 4?
The procedure was done on day number 4, yeah.
4, yeah, okay.
And Dr. Basir, just to comment on something you said, I was going to go on a whole tangent, but it was a limited time, about how the new door to lactate, it's really remarkable that she came in with an 8.3 lactate, and we just never trended that. It was actually one of the first questions when we were looking back at the case. Dr. Nathan was like, oh, what are her lactates? I'm like, we just have 8.3. And then we never tracked that. So I think if we were able to serially track that, we could have intervened, maybe not at day 4, maybe a little bit earlier.
And I think the point is, I'm glad you said it. The point is that we have an established shock program for many, many years. We could still do a lot better.
Congratulations, perfect. Yes, go.
Yeah, congratulations on a great case, and I attest to Babar's comments that you did a really refined job. Question to the panel, Sandeep, going back to the viability testing and revascularization, I feel there are a lot of times we're stuck in this situation with MCS and everybody's debating about viability, and you have a competing interest of high-risk PCIs monitored in the cath labs. It gets difficult to convince interventionalists to take a higher risk in these individuals, and becomes easier to do a VAD and transplant because MCS support has become so good. And we have cases where, depending on who's looking at it and what argument you make, you are avoiding VADs and transplants. So my question to you is, how do we break that cycle? Is there an option to either get these shock patients who are getting PCI to some extent as too high risk and get them out of the registry so people are not behaving based on risk-based benefit? What's the solution, you think?
I don't have a nice buttoned-up answer for that. I will tell you that in this case, we did talk about VAD transplant, too old for transplant and not dilated enough for VAD was the concern. The PAD was also a concern. But you're right. I think that we do sort of take a pass on more durable therapies for patients than trying to fix this. I think this was a case maybe worth talking about because it falls out of every clinical trial. There's not a single clinical trial that addresses a patient like this, but these patients are very common. They show up in our ERs all the time, and we just kind of scratch our heads and do the best we can. We did talk about VAD transplant, and there were, in her case, there were multiple red flags.
Good for her.
Thank you. So we're going to move on. Next case is going to be presented by Manuel Jimenez.
invitation. I was a fellow for 11 years, but I, of course, not anymore a fellow. So on behalf of my fellows, I am here, so thank you very much for the invitation. So I'm going to present you a case of sustained functional recovery after an anterior STEMI, with a cardiogenic shock, SCI-E. So this case was and is a male, 15 years old, with hypertension and dyslipidemia, using only aspirin and losartan, and he presented to our emergency room with a heart rate of 105, blood pressure of 88/60, and a saturation of 88. This happened in January, not in August. He was having typical angina, and in another hospital they performed an ECG with an anterior ST segment elevation, and they performed fibrinolysis, which was a failed thrombolysis. So he developed hemodynamic instability. So our center performed a 4-chamber TTE, showing this dilatation with an ejection fraction of 15, with mild mitral regurgitation and global hypokinesia. This is the ECG in our center. He presented with a lactate of 4.7, and then he escalated this lactate to 11. So our first consideration was to perform a primary or a rescue PCI with EABP. So this is the numbers. So we started norepinephrine, vasopressin, and dobutamine at the same time that he was going to the cath lab. And we find the 3-vessel disease. I'm going to show you that. And also the LVDP was 32. So after this, we moved from EVP to Impella CP, and the numbers to get the SCI-E classification are there. So we were able to remove the Impella 2 days after, and you are going to see the reason why we did this. This is the screenshot of the LVDP of 32. So we check it multiple times. So most of the times this kind of patient has chronic total occlusion. So he was having a chronic total occlusion of the RCA, and very severe disease, and also a chronic total occlusion of the CX. So he was leaving because of the LAD that has also an STEMI. So it was a failed thrombolysis because of the ECG, but luckily the LAD was open. So in the left side of your screen, you can see the angiogram with an EAVP, and then we move on to the Impella CP in order to perform the rescue PCI. So it was a kind of easygoing PCI, but during the procedure, the patient presented 3 and maybe 4 episodes of loss of pulsatility. So because of the multiple episodes of loss of pulsatility, we kept the Impella for 2 days. This is the final image of the angiogram. And after this result, we were happy with everything. So in the follow-up, 60 days after, the patient has an ejection fraction of 40 with this kind of hypokinesia in the apex. So yeah, that's the case of our fellows. So the take-home messages for us is that early attention of cardiogenic shock is essential for the treatment. The use of early ventricular assist improves the possibility of optimal results. And even in these kind of cases, as I showed you yesterday, some patients, even in the primary PCI setting, they don't recover the ejection fraction. So sometimes I think that there is possible distal embolization, not only a time issue, but sometimes even when you perform a primary PCI, the recovery is not total. So yeah, that's our take-home message. Thank you.
Very good. So, Vicente, you want to make any comments?
Yeah, congratulations, Jan, for a great case.
Thanks.
I think that in this type of cases, the proper or multidisciplinary evaluation of you know, the complexity of the anatomy, but also I think if you look at the images of the angiogram, this LAD looks like it's perfusing a maybe not viable, not viable part of the myocardium. I think the flow and the que tan delgado estaba el vaso, ¿no? Se ve como un vaso que estaba muy fino, como que el flujo en esa zona. I don't know if the evaluation of viability, I mean, you got good support with the Impella CP, but I don't know if sometimes just to rest the heart and then decide what should be the best revascularization strategy in this type of patients. So I think using balloon pump in these cases in the majority of hospitals in Mexico works as a first strategy. But once you decide to go for Impella CP, that you have an active unloading of the heart. I think in these cases where there's no real viability evaluation, maybe just resting the heart and then stabilize the patient and then decide what should be the best revascularization strategy. Is it going to be a PCI or a full revasc with the surgery?
We went for PCI because he was having these two chronic total occlusions, the CX and the RCA, and also because there was thrombus in the LAD, so we were thinking that maybe he was not going to make it until the surgery, and especially in this kind of patients having a cardiogenic shock, we prefer to go for the primary or rescue PCI, especially when thrombus is in the artery. And even when, as you said, the flow is not optimal maybe, there is flow to this big or very big septal and also to the distal LAD, and all the segment with thrombus was stented. So I will consider maybe to stabilize the patient and consider surgery, was especially in our center, is almost impossible for us to convince the surgeons to perform a CABG in a patient that was having cardiogenic shock recently. But it is a kind of option.
Yeah, thank you, great case. I do have to disclose that I'm not an interventionalist, I'm an imager. So, but one of the things that we as imagers, and especially those who do CMR, we often see more frequently microvascular obstruction in patients with thrombolysis. And it's probably you can have an open artery, but you can have underlying damaged tissue. And my question to you, who do shock and interventionalism, is have you found a different development of the patients towards time when they undergo thrombolysis versus primary PCI, and what would be the paper of the microcirculation in these cases?
Yeah, I think that maybe because it was a failed thrombolysis in the ECG, but not anatomically, there was microvascular obstruction almost for sure. So I think that the recovery or the optimal flow given by the stented area, and also because of the power or the optimal coronary flow that Impella gave us, is a reason that because of this patient recovers. So I think that even with this potential microvascular obstruction, the patient recovers almost to normal ejection fraction. So I think that that's the way to go maybe in these kind of cases. Of course, there was microvascular obstruction in our perspective.
Yes, Barbara.
Yeah, so I think it's come up in this case and in the last case. Surgically was historically the best revascularization strategy in shock because patients went on cardiopulmonary bypass. And that support helped them out of their struggles more than anything else. We're in a state now where we can provide that same level of hemodynamic support. And we have to really, I think, assess in our patients how feasible and easy PCI is. And in the fact that PCI is relatively straightforward, then I think PCI is a safer option in patients with cardiogenic shock. And we saw 2 cases that had somewhat delayed revascularization, not the second case because you did primary PCI right away, but some thought about waiting until you have a surgical outlook on this patient. And I think we hurt lots of patients by waiting for that option. I think ultimately, if you have competent operators that can do complex interventions, the standard of care should probably be to offer them PCI and revascularization. And it's, to Arvin's point as well, is that, we also have this outlook that, oh, you know what, maybe they can get LVAD and transplant. They can still get LVAD and transplant with stents too, right? So you can give them the chance to recover thereafter. And yesterday there was multiple great case examples or discussions about the idea of putting somebody on a 5.5 and waiting 3 months, and Jacob showed what happens to a pig when you do that. That may be the future where you can revascularize them, put in a support, and then just wait and wait.
Hey, Barbara, and what's your opinion on opening CTOs? What should be like the ideal timing for doing CTO in revascularization in patients that present with cardiogenic shock?
Yeah, I think you ultimately have to take a huge step back when you're looking at the CTO and talk about how complex is it, right? I think Sandeep opened up a CTO, right? But he was able to just do straightforward wire escalation and put in a stent, and then the patient did well from that standpoint. And I think you have to have a higher or be more aggressive about opening up an LAD than a CIRC or an RCA. But at the same time, I don't think any of that needs to be done in the culprit setting. Almost extremely rarely done, right? And I think ultimately the downfall of culprit shock was because of the inclusion of CTOs. In fact, if you look at the exclusion of the CTO, there was no difference in the primary endpoint, and that includes the acute kidney injury endpoint. So if you take out CTOs, you decrease the contrast dose a lot, and patients did just as fine, not just at the 30-day mark, but also at the 1-year mark.
So a comment and a question. So the comment, I thank you for raising the issue of thrombolysis. It's interesting. I mean, I think that as interventionalists, we believe that once we have TIMI-3 flow, everything is good, the microvasculature is spared and so forth. And there's good data that goes back now quite a number of years. Greg Stone published a pooled analysis of 7 primary PCI trials showing that 60% of revascularized LADs have evidence of microvascular dysfunction if you have the right tool to look for it, either CMR or if not CMR, SPECT. Suzanne DeWaha has published the same sort of thing. So I think that it's sort of out of sight, out of mind. We don't see the microcirculation and we just assume it's good. I will make a plug for supersaturated O2 in these cases, maybe not the stage E shock case. And then, the Faraday Pharmaceuticals compound FDY5301 is in the late stages of its clinical trial. It's a sodium iodide analog that decreases inflammation. So there's, maybe a couple of adjuncts in addition to, an excellent PCI result. My question is exactly the question that was raised. What is, by Vicente, what is the timing of the additional work look like here in Mexico at your center? How long do you wait? Do you sort of wait until functional recovery of the patient, a month, 2 months before you come back for that CIRC CTO? What does that look like?
What we do in our center is to wait at least 3 months, especially for the total recovery or potential recovery of the primary PCI in the LAD. But if something happens with hemodynamical instability or wherever, we go for that. So because it was a very typical chronic total occlusion, we wait 3 months.
So I just want to add, again, would you go straight forward to Impella instead of putting an IVP when the patient presented with that echo, 15% left ventricular ejection fraction, and he was in shock? So do you think to go straight to Impella instead of a balloon pump?
I mean, I think in our center we would. I think that the problem with balloon pump is that and this was discussed yesterday, we don't know who actually responds. We have a sense of it. Dave Barron has done work. Naveen has done some great work dating back over 10 years on the phenotype of the responder. So they have a resistive load. They have, aortic compliance that allows for that blood to be shuttled. They obviously have a patent, a competent aortic valve and so forth. But, at 2 in the morning, you don't know if this patient's going to respond or not. So it always becomes a little bit of a, question mark, what you get when you put it in. And once that patient fibrillates, all bets are off.
Mm-hmm. Yeah. So kind of if it's a waste to use the balloon pump and then, because you're probably going to escalate, Any other questions, Marwan?
Thank you.
Okay, thank you, Jan. You want to present the next one?
Next up is Dr. Dhruvil Patel presenting a case of mixed refractory shock in a young peripartum patient with mechanical circulatory support. Dhruvil is also from University of Chicago.
Good morning, everyone. Try and press the green button.
¿Pueden ustedes poner la presentación?
Sorry, I'm not able to move.
Yeah, they're going to help you here. Yeah.
Thank you. Oh, there we go. Now it's working. Perfect. Good morning, everyone. My name is Dhruvil Patel. As Dr. Nathan mentioned, I'm a third-year internal medicine pediatrics resident at the University of Chicago. I'd like to thank Dr. Jimenez, Dr. Torre, and the entire Tech Salute team for allowing me the privilege to present this case here. The case is titled 3 Bridges and a Destination. These are my disclosures. Oh, thank you so much. So for background, heart failure cardiogenic shock still represents the majority of cardiogenic shock presentations, yet remains underrepresented in trials that define cardiogenic shock treatment strategies and management. More specifically, in comparison to acute myocardial infarction cardiogenic shock, heart failure cardiogenic shock still has slightly lower in-hospital mortality, although long-term outcomes are pretty comparable between the two, with mortality often being higher in heart failure cardiogenic shock patients. Furthermore, invasive hemodynamics for these particular patients is very helpful in guiding management, but in cases of severe heart failure cardiogenic shock, predominant left ventricular failure may benefit from mechanical circulatory support, particularly initiation of microaxial flow pumps, but progressive severe biventricular dysfunction may benefit from escalation of the initial mechanical circulatory support with some options that everyone in this room is familiar with here on the right. Given the background, I wanted to present our case here of a 21-year-old female who had a pretty uncomplicated pregnancy history as well as a birth history and gave birth full term via spontaneous vaginal delivery, but her postpartum course was complicated by endometritis, for which she received antibiotics for 2 days, and after resolution of her symptoms, she was discharged home. But on post-delivery day 11, she was admitted again to an outside hospital for abdominal pain, nausea, and vomiting, for which she was transferred over to our center. Some of the highlights of her initial workup included a CT chest, abdomen, and pelvis showing excessive abdominal pelvic abscesses. She was also gram-positive coccobacilli from her blood cultures, and her antibiotic regimen was broadened. Of note, some of the events that occurred throughout her initial course included an interventional radiology-guided drainage of purulent ascites fluid, about 1.3 liters of it. Over this course, as she got transferred into our hospital, a few other incidents that occurred as we tried to achieve source control over the course of this month included recurrent abdominal abscesses that required drainage placements. She also received a video-assisted thoracoscopic surgery for organizing pneumonia and exploratory laparotomy for washout of adhesions, as well as a perihepatic hematoma and a right lower quadrant abscess. But in this setting, a lengthy hospitalization course ensued, for which she produced and progressed to multi-organ dysfunction and progressive shock. Now, over this setting, as we attempt to get source control, we also subsequently continue to assess our cardiac activity, particularly in response to persistent hypoxia as well as persistent pulmonary edema. And over the course of that time, we discovered newly discovered reduced ejection fraction with biventricular dysfunction, showing about a left ventricular ejection fraction of 20%. And as a reminder, this is a very young patient. She had no other comorbidities and no other prior cardiac history. But in the setting of this progressive shock, this new HFrEF revealed itself. In the setting of this HFrEF, she also became persistently hypotensive, and as we were trying to attempt source control, she required further escalating vasopressor support, particularly dopamine and norepinephrine. And at this point, with this reduced function, with multi-pressor shock, she eventually was transferred to the cardiac ICU and received a right heart cardiac catheterization. The numbers you see up here, some notable points include an elevated RA pressure of 18, an elevated right ventricular systolic pressure of 46, and a diastolic pressure of 22, a very elevated pulmonary capillary wedge pressure of 40, a mixed venous saturation of 60% though, and a fit cardiac index of 2.86, all in the setting of multi-pressors, indicating a mixed cardiogenic and septic shock picture. Now, given the context of this progressive shock, her clinical status is worsening, a shock team discussion was activated with these particular metrics kept in mind, specifically invasive hemodynamics, as indicated by the increased biventricular filling pressures. She also at this time had a persistent lactic acidosis that slowly continued to rise while on multiple pressors, and the discussion involved the fact that we had newly discovered HFrEF. All of this resulted in a goal from the discussion to be able to potentially wean her off of afterload, vasopressor support by way of decreasing her afterload, with the goal of placing an Impella CP, giving her about 3.5 liters of output. Now, after the Impella CP device was placed, she was taken back to the cardiac ICU, but over the subsequent 6 to 8 hours, she still required escalating vasopressor doses. She had a persistent rising lactic acidosis, and thereby a shock team meeting was reconvened, at which point the decision was made to escalate mechanical circulatory support. Now, keep in mind that this case happened over the weekend. The shock team immediately reconvened at this time, and Dr. Nathan was the one who took her back to the lab. Here we see images of escalation onto VA ECMO. Particularly, we have access, antegrade access of the superficial femoral artery with a 6 French arterial sheath placed in for perfusion. This angiogram on the right does show there'd be occlusion of the SFA, but perfusion still present through the sheath. Furthermore, we had a venous cannula advanced into the common femoral vein, which was then straddled between the inferior vena cava and superior vena cava, as well as a 17 French arterial cannula placed in for arterial perfusion. At the same time, the Impella CP remained in, as a result escalating this patient from initially an Impella CP to ECPella support. Over the next 3 weeks, while on the support, the patient had improved end organ perfusion markers, particularly a decreasing lactic acid back to normal. She also had improved hemodynamics, but she persistently still had biventricular dysfunction, which remained very severe despite attempting to try guideline-directed medical therapy medications, and thereby extensive discussions with both the patient, the family, and the cardiac team, a decision was made to proceed with a durable surgical left ventricular assist device. So on day 60 of her hospitalization, she received a Heartwear LVAD device. Just to note, this case was done about 6 years ago. The Heartwear device is off the market, but it just has not been presented till yet. She also received a temporary Oxy-RVAD in the setting of this LVAD being initiated, which was weaned off 5 days later. And then later she received a tricuspid valve repair and a delayed sternal closure. Putting her course together on day 84 of hospitalization, she was actually able to be successfully discharged and out of the hospital for over 9 months and subsequent follow-up with compliance with their guideline-directed medical therapy. She eventually had recovery of her ejection fraction to about 40 to 45%. Now, at this point, there was a discussion made on potentially surgically removing the LVAD, but keep in mind that for the first 3 months of her life, this poor lady, unfortunately, was in the hospital while her baby was at home, and the prospect of going back to the operating room to get this device removed was very daunting to both her and her family, and thereby a joint decision was made with the cardiac team to actually decommission the LVAD while it was in the body, allowing it to thrombose. Specifically, she was taken back to the cath lab and a reverse ramp study was done, at which point there was successful hemodynamics seen compensated by the patient's own cardiac activity at about 1,800 revolutions per minute. And after about 11 months, when this patient was first placed on ECPella support, her LVAD was successfully decommissioned by Dr. Nathan in the cath lab with a 14 millimeter AVP2 vascular plug that was placed within the LVAD outflow cannula. The images you see here on the left do show the LVAD outflow cannula before the plug and then after the plug as well. Now, some key learning points here, particularly in the form of initiating mechanical circulatory support. For this patient in particular, initiation of ECMO immediately in severe cardiogenic shock has not shown to have any mortality benefit, particularly in the early load and the ECMO cardiogenic shock trials, yet there is presence of complications. The important piece of our patient's course was that we had a discussion about initiation of, shall I say, less invasive mechanical circulatory support to then more invasive, and particularly allowing us to be able to adjudicate and assess if this less support and thereby maybe less risk of complications could be something that can be passed for this patient. And finally, the involvement of our multidisciplinary shock team was very crucial and very vital to be able to treat this patient. And specifically, some important points include being able to assess with hemodynamic markers, considering the early initiation of MCS in these discussions, immediately reacting to initial clinic and hemodynamic parameters, but then reassessing and being reactive and proactive to subsequent decompensations, and having regularly scheduled shock team discussions that proved very vital to be able to escalate this patient onto more intensive care. Finally, just an important point that was a very great point of consideration in our shock team discussions was escalation of percutaneous support when appropriate, particularly to biventricular support, can serve as a bridge to either decision or transplant, and in this case, a very remarkable recovery. I just wanted to once again thank the Cardiogenic Shock Symposium organizers and facilitators for allowing me to present this case and the wonderful accommodations we have here, and finally to Dr. Sandeep Nathan for his incredible mentorship, encouragement, and guidance. Thank you everyone for your time.
Great presentation again, great case. I was wondering, or this is a question, for how long would you leave an Impella CP on a patient? Maybe this patient, you could have maybe predict that she was going to have support for a longer time, so I mean, it was on a weekend, so maybe you had to do an Impella CP, but maybe you also could consider at some point Impella 5.5. So for how long will you leave an Impella CP in a patient before moving to something else?
I think from my experience, rotating in the cardiac ICU, I've seen them in anywhere between 3, 5, and sometimes even a week. I have not seen anything longer though, but I will say I have never implanted one.
And it was considered to change to Impella 5.5?
Yeah, I think now we would probably have done a 5.5 and just kind of dug our heels in for a longer period of time. Part of that decision was informed by this belief that we had gained source control with all of the washouts and surgeries, and maybe she just needed a short period of support. The point that I think you're getting at is a very good one, that, beyond 96 hours, it sort of becomes diminishing returns, right? Hemolysis and suction events, and, now the right ventricle is failing and so forth. So, I think that were we to redo this case, when this kind of patient presents now, I think we're much quicker to go to a 5.5, but, would love to hear what Marwan and Arvind, Babar, what anyone else would do here. Would you have done something differently?
I think one thing to consider is potentially lava ECMO, right? Just saving one vascular access from that standpoint. And the other thing is that it drives a lot of hemolysis, kidney injury, transfusion, and things like that. But I mean, again, I think this is just such a challenging case. I mean, you lost me at, I would have bowed out at pregnancy, postpartum pregnancy. Then you talk about everything else that this poor woman had to go through after the month. I mean, it's really a great save.
What are the capabilities here in Mexico? Is 5.5 feasible?
Not yet. It's about to be released in Mexico, maybe in the next 1 to 4 or 5 months. But so far we will have like ECMO and Impella, the same like ECPella.
And so I think, I'm sure you've had internal discussions about who would be a candidate for a 5.5. Do you have some sort of road rules? I mean, I'm guessing that there's the same pricing structure where 5.5 is quite a bit more expensive than even a CP.
Yes, can you give him, open the mic for?
No, it's fine. It doesn't, now it works. So Bobby, I think, is going to talk to us and see what would happen here over the next few months. But at the moment, we don't have 5.5, and it's a real problem because we don't have the ability to have all these variety of support strategies. So VA ECMO becomes very important. I think we talk about LAVA ECMO. We have not really done it, but I think that's a very good probability in a situation like this. Now, the other major issue that happens is that when in Mexico, people are not exposed to cases like this. I mean, very few centers will have the ability to do what you did here. And probably that's true all over the world, with the exception of the US, maybe a couple of places in Europe. So when you face a situation, a clinical problem like that, and you have the family around, when they see all this multiple surgeries, lots of support devices, and the expectation is unclear. I mean, you have a terrific outcome at the end. But the honest truth is that nobody can state at the beginning that you're going to be successful at the end. And, I mean, she survived because she's young, had great doctors and all the support in a terrific facility. But it's really a challenging case, not only from the ability to have resources, but also the dynamics of keeping the family supporting all these different strategies. I think that's a very big challenge. I don't know how we go about here, but I would imagine that things like this are in Mexico are very difficult. I mean, we've gone through complicated cases, and it's even sometimes more difficult just to maintain this family support and the patient support than all the other issues. But
I think it's a very valid point, and you just think about it's a great save, and a human life was preserved, but an enormous amount of resource expenditure to keep that person on this earth. Now, I will tell you parenthetically, she's alive and well 5 years later. She still has her LVAD, her thrombosed LVAD in place. And she's alive and well. Nurse practitioners reached out to her last week and talked to her. So, but I think that this is not the right reason to do anything, but there was a lot of emotion around the fact that she had a healthy baby at home, that she had something to live for. And, we just have to keep pushing. And the family was behind that.
Yeah, no, I understand that. The question I was going to ask you, what are your plans for the VAD? Are you just going to leave it like that, or planning to explant that
I mean,
at some point?
we've tried. We don't feel good about leaving that much hardware in somebody, and I'd love to hear if somebody else has experience with this, and Manrita's back there. So, we have tried to bring her back into the fold to get this removed, but, she's been reluctant. I think she was very much traumatized, understandably, by 3 months in an ICU.
So to the question about leaving the VAD in. So if you look at the VAD-Veen registry, which is about 500 patients who've been explanted, about half of them have a VAD left in, and the other half had it completely explanted, because it does take another open heart surgery to be able to do so. The outcomes are no different. The concern always is that is there a nidus for infection with a thrombosed pump in there? But it becomes a sort of patient-specific decision. Do they want to undergo another sternotomy? Especially if those patients who we are not sure are going to recover or not, we sometimes leave the VAD in rather than do another sternotomy in case they have to be eventually listed for transplant. Because the idea is when you explant the VAD, you have to plug the LV apical, hole that is left behind, and it takes away from the LVEF from the normal function of the heart. So if you're not sure if you're going to be successful with a VAD-Veen strategy, we sometimes leave the VAD in case they need to be eventually transplanted, in which case then you're not doing one more sternotomy. In my previous experience, we've always explanted younger people because of unknown risk of leaving things in them. But older folks who don't want to undergo another sternotomy or have other reasons not to do so, the outcomes are the same so far.
But the outflow tract, the graft is plugged. I guess I didn't get it, but you're putting a plug on the.
Once the VAD is shut down, just to minimize the chances of flow reversing in that.
Good, yeah.
So we've done a bunch of these, and we always size it with IVUS, because the outflow graft is always different than what the the IFU says it is once it's been pressurized. So we IVA-size it and then just upsize, a vascular plug. This was a 14 millimeter AVP2.
Yeah, I think to add to Manrit's comment, the observational data is showing that it doesn't make short-term difference whether you take it out or not. But at least in our experience, in a few cases, the infection becomes a problem. It catches up at some point. It also depends on how much was there before. So we had one case where we just decommissioned, left it alone, and then had more infection. So we were forced to explant. But luckily, by that time, one of our perfusionists has a patented plug which gives you the ability to leave the sewing ring in. So you actually just plug it out. And if you need to put a VAD in, you can just unplug it and put it back. So we're able to get a FDA humanitarian exemption and do this. And this guy has been out for a couple of years. So I think that space of what you do with the Apex is still evolving.
I think the interesting sort of side note to this is, as disastrous of a course as she had initially, she's had basically an event-free 5 years afterwards.
Just a couple of comments. Number one, this case demonstrates two things to me. Number one is the value of innovation and perseverance. Most RV dysfunction gets better, and if we had at the time a 5.5, maybe the approach to managing this patient is probably different than implanting a VAD. Question number two that I have for everyone in the room is, if we do genetic testing on this patient, she's young, and let's say her LV on imaging shows recovery with an LVAD, but she's a Titan gene mutation positive, for example, would your approach of how you decommission or whether you decommission change?
I don't think we know enough. There are some Titan variants which have a prognostic implications. We'll have to look up the literature on it. But for the most part, because we see fluctuating cardiomyopathies in Titan variants as such. So I wouldn't probably just make the decision based on that, but it's a good question. Would you genotype individuals to know what the trajectory is?
But if he was genotype negative, I guess, would you be drastically different? I mean, I think that genotype negative, you still have maybe a big portion of those that we just don't know the genes. So, I mean, the origin of the initial dysfunction may be just the septic state, right? So she might have had just a combination of factors. Yes, was in a peripartum cardiomyopathy condition, but it's also not a typical situation. I mean, this lady was septic for quite some time, and maybe sepsis-induced LV dysfunction could have precipitated maybe in a background of some predisposition to develop cardiomyopathy. But I think the fact that it recovered, I guess it would argue that I would think that she doesn't have a genetic mutation that would bring her. Have you done genetic testing?
We didn't go down that path of genetic testing because there were probably 3 other credible reasons why why she was had this cardiomyopathy.
Thank you so much.
Thank you.
Okay, so we're gonna move on with the program. Thank you so much, and please get many cases for next year. So tell your fellows to be aware of the cases for next year.